Okay, now we're going to talk about adult primary brain tumors. In here we have a couple of tumors. First of all, we have the glioblastomas, oligodendroglioma, meningiomas, hemangioblastoma, pituitary adenoma. So let's take a look at the first one, which is glioblastoma. Glioblastoma is highly malignant primary brain tumor with 1 year median survival, found in cerebral hemispheres, can cross corpus callosum, butterfly glioma, associated with EGFR amplification. On histology, because the glioblastomas are astrocyte origin, they will be GFAP positive. Pseudopellisating will be seen of pleomorphic tumor cells with border, again, pleomorphic tumor cells border and central areas of necrosis, hemorrhage, and our microvascular proliferation. Now let's talk about how can we memorize all of this, right? So the easy way, what is this? Easy way to memorize glioblastomas are, first of all, we got to know that they are the astrocyte origin. Astrocytes are the major cells. Astrocytes are always GFAP positive. Okay. Now to memorize this is a simple thing. We are going to call it, instead of calling it glioblastoma, we will call it glioblastoma. So GLIO blastopoma. It is a glio with a blastopoma, glioblastopoma. So G for GFAP positive, B for butterfly gliomas. Butterfly, now important point here is butterfly, all it means is this is the only one that you will see that is going to cross the corpus callosum. So let's take a look at image A first, so you kind of get the idea. Here, if you look at this, it's crossing. This tumor is not only one side, it's crossing to the other side. So it is crossing the corpus callosum, right? And this sort of makes a shape of a butterfly. That's why I call the butterfly shaped tumor. And the last thing we're going to think about is the pseudopellisating. So P for pseudopellisating. So again, G for GFAP, B for butterfly gliomas, which means they will cross the corpus callosum. You will see on the bilateral side. Okay. P for pseudopellisating. And this is going to be the high yield points on this. And one important point that there's there's a 1 year median survival. It's a very low survival rate. Then you have the next one is oligodendroglioma. They are rare and they are slow growing, most often in the frontal lobes, often calcified. Oligodendrocytes origin, as the name suggests, oligo, right? And if you recall, oligodendrocytes are fried egg cells with the round nuclei with clear cytoplasms, right? So the mnemonic that we did talk about was oligodendroglioma. Remember? Oligo. And if you don't recall that, you can go back to neuroanatomy, see that it's called oligo. So oligo for the fried egg appearance of the cell. And whenever you have where does egg come from? Egg, I mean, the eggs that we eat are coming from chicken, right? So you will associate a fried egg appearance with chicken wire capillary pattern. So chicken, egg, if you see something like this, you're going to call it oligo. Oligo. Ego is the main thing here. Oligo. And that's going to be it for oligodendrogliomas. Then next we have is meningioma, coming from meninges, right? Which meninges? Arachnoid cell origin. if you recall, you had meninges, right? All the PAD, pia matter, arachnoid dura matter. So meningiomas is arising from arachnoid cell origin, which are the meningothelial cells. All right. Now this is typically benign. Females greater than males occurs along the surface of brain or the spinal cord, because if you recall, meninges run along the surface of spinal cord and the brain, right? So not a big deal here. But the important thing is this is extraaxial, meaning again external to the brain parenchyma for sure, because the meninges run external to the brain parenchyma. May have dural attachment with the tail E. We'll take a look at that later, but let's read first. It is well circumscribed, spherical or lobular shape, often asymptomatic, may present with seizures or focal neurological signs. Treatment is resection and or radiosurgery. Now, it is arachnoid cell origin with the spindle cells concentrically arranged in a wall pattern called high-yield psammoma bodies. What are psammoma bodies? They're laminated, calcified. So let's take a look at psammoma bodies and dural attachment with a tail. Picture E and F. So if you look at picture E, we have, if you, let's just zoom in. Do you see the tail here? There's a tail, right? Attachment to the dura makes a tail shape. Tail of this. So this is the meningioma with the tail. And tail is there because it has a dural attachment. So this is the dura that's running. It has a dural attachment. That's why you see the tail. And you can see that over there. Now, the next thing was psammoma bodies, which is picture F. So psammoma bodies is, again, if you look here, you have the wall pattern of laminated calcification. So you have a laminated calcification of wall pattern called psammoma bodies. Right? Now, let's go back to the text. So how do we memorize meningioma? Well, for meningioma, the good mnemonic here is going to be men have PSA problems, right? Excuse me. Men for meningioma, they have PSA problem. If you recall, what is PSA again? PSA coming from your prostate, right? So men have PSA problems. That's a normal thing. I mean, not normal, but common thing to see in males. So that's the mnemonic. Men for meningioma have PSA problem. What is a PSA now? P for psammoma bodies. S is for the S is going to be for spindle cells, and PSA for, again, arachnoid cell origin. PSA for men, meningioma. And that's going to be all for meningioma. Moving on with heme angioblastoma. Heme means heme. Angio means blood vessels. Blastoma is just a tumor. Most often cerebellar, associated with von Hippel-Lindau syndrome. When found with retinal angiomas, can produce EPO, erythropoietin, which leads to secondary polycythemia. It is again a blood vessel origin, because angio means blood vessels, blood vessel origin. Commonly arranged thin-walled capillaries with minimal intervening parenchyma. Now, if you recall that von Hippel-Lindau, we called it von Harp-Lindau syndrome. And Harp, the first age was for hemangioblastoma. And here it is. Von Hippel-Lindau, hemangioblastoma right there. So we have to associate this with von Hippel-Lindau. So blastoma, von Hippel-Lindau syndrome. Blood vessels, it's a blood vessel origin. Heme, with a heme, you can think about secondary polycythemia due to EPO release. So these tumors that release EPO causes secondary polycythemia, increasing hematocrit. And that's the heme. So heme, again, EPO, blood vessels, meaning blood vessel origin, Blastoma, meaning you have a von Harp-Lindau syndrome association. Let's take a look at picture H, in which we have the thin wall capillaries with minimal intervening parenchyma. Okay, first look at G. It is you can see it's arising within the cerebellum. This is the cerebellum. That's picture G. And picture H, thin walled capillaries. Thin walled capillaries with minimal intervening parenchyma. So you have a thin walled capillaries here, because you can see all these RBCs just out there. It's a thin walled capillaries. Okay, that's there. So again, the mnemonic is going to be for hemangioblastoma is heme. Heme angio means blood vessels. Heme means EPO, erythropoietin. Angio means blood vessels. Blastoma, it is associated with VHL, von Harp-Lindau syndrome. Okay. The next is pituitary adenoma. Well, pituitary adenoma is most common. Also important. It's again, it's very simple. It is first of all, you can have a non-functional, which is known as a silent tumor, or hyper-functioning, meaning hormone-producing tumor. Right now, the non-functional, meaning whatever the adenoma is in the pituitary, it's non-functional. It's not going to produce any hormone of the pituitary. So it's going to present with mass effect. What that mass effect will give you bitemporal heminopsia due to pressure on the optic chiasm. So it's going to compress that optic chiasm. And when it compresses on the optic chiasm, it's going to cause bitemporal heminopsia. Okay. And on top of that, it's also going to cause headache. So headache and mass effect. So that's only with the non-functional tumor. Let's say if it's a functional tumor and it secretes lactotrophs secreting tumor is going to release prolactin, causing a name as prolactinoma. Now, with the prolactinoma, you have increase in prolactin. So that's going to present with galactorrhea, amenorrhea, decreased bone density due to suppression of estrogen in females, and decreased libido, infertility, gynecomastia in males. That's again, we will talk about that in endocrine section. But here, lactotroph prolactinoma and the sign and symptoms. The third thing we will think about is if it's a tumor of somatotrophs. Somatotrophs are your growth hormone. If you have a lot of growth hormone, then it's going to cause acromegaly or gigantism. Or you could have a corticotrophs tumor, which is ACTH, which can lead to Cushing disease. Rarely, thyrotrophs, which can lead to TSH producing tumor, or gonadotrophs, which can lead to FSH and LH producing tumor. But most importantly, you can think about these two non-functional, all giving the headache and mass effect, and lactotrophs causing prolactinoma. The treatment of pituitary adenoma is dopamine agonists. Example, bromocriptine and carbagoline. And transsphenoidal resection is, if it's treatment resistant, then you just go for transsphenoidal resection of the pituitary adenoma. And if you recall, you have dopamine, which was inhibiting the release of prolactin. So if you give dopamine agonists, you are going to inhibit the release of prolactin. And if it's a tumor, that might not work. So that's why you want to go for resection of it. Okay. On the other hand, it's the pituitary adenoma is a hyperplasia of only one of the types of endocrine cells found in the pituitary. Most commonly, the lactotrophs we talked about, prolactin, causing hyperprolactinemia, and less commonly the rest of these that we talked about. Okay, so this is a fairly simple one. I mean, there isn't a big deal. It's just a simple physiology and pathology. So, I mean, just to recall, the whole important thing in this one is it's a non-functional mass effect headache. Functional, most common is prolactinoma. which is going to give you signs and symptoms of increase in prolactin. Less commonly, it can be somatotropes, corticotropes, or gonadotropes, or thyrotropes, any one of the hormones, any one type of the endocrine cells coming from the prolactin. The last adult primary brain tumor is schwannoma. Schwannoma is classically at the cerebellopontine angle. Cerebellopontine angle, high yield. And it's benign. It commonly involves the cranial nerve 5, 7, 8, but can be along any peripheral nerve, often localized to CN8 in the internal acoustic meatus, which leads to vestibular schwannoma. And that will present with hearing loss, tinnitus, and unsteady gait. So this, now again, I want you to think here, what you have here is going to be unilateral. So if there is an internal acoustic meatus, a localization to cranial nerve 8, basically named as vestibular schwannoma, this is going to give, it is only on the one side. Okay, so it is an ipsilateral vestibular schwannoma that's going to present with hearing loss, tinnitus, and unsteady gait. Now, if you have a bilateral vestibular schwannoma, then you think about association with neurofibromatosis type 2 or neurofibromatosis 2, NF2. If you recall, we talked about a mnemonic in NF2 as 2 eyes, 2 ears, and 2 brain structures, right? So here's the 2. So 2 ears is going to affect bilateral vestibular CN8, causing schwannoma over there. So what is schwannoma itself? What's the origin? Well, as the name suggests, Schwann cells, schwannoma, right? So Schwann cells origin, when the Schwann cells have origin of S100, they're all S100 positive. Just one thing recall, what else would be S100 positive? And that's going to be melanoma. But we will talk about that later. But here, S, all the S's. So Schwann cells, S100 positive. It's a biphasic, dense, hypercellular area containing spindle cells alternating with hypocellular myxoid areas. And they haven't mentioned something, myxoid areas with palisading verrucae bodies. With palisading verrucae bodies. Okay, so one more thing is going to be when you call it ipsilateral vestibular schwannoma, there is a specific name to that, and that is called acoustic neuroma. Acoustic neuroma. And when it is bilateral, you know that it is associated with NF2. Okay, and let's take a look at picture K for CPA, cerebellopontine angle, and L for the histology. Okay, so here's the cerebellopontine angle, and you can see bilateral. You can see how it's affecting bilaterally. And you have the other picture, which is just, if you look in this picture, you see hypercellular. What do you see? A lot of cells, right? So hypercellular areas containing spindle cells. So there are hypercellular spindle cells with palisading. If you look at these, the picture, it's a palisading sort of they're palisading with verrucae bodies. That's an extra thing. So you have verrucae bodies there as well. And that's going to be all for primary adult tumors. Let's just review this. Okay. So primary adult tumors. First of all, we have glioblastoma. We're gonna call it glioblastopoma. So it's a GFAP positive for the G for glio. B for it's a butterfly glioma, meaning it's going to cross the corpus callosum. It's the only one which is going to cross the corpus callosum. And for the P is due to the fact that it's a pseudo-palisading. If this one is pseudo-palisading, so which one is actually palisading? So that's your schwannoma. Here the cells are actually palisading, so you call it palisading. Palisading cells with verruca bodies. But again, going back to glioblastoma, that's again most common, only 1 year median survival. 1 year median survival. It is associated with EGFR amplification. It's an astrocyte origin, that's why GFAP positive. Okay, the next one is oligodendroglioma, which is all oligodendroglioma, meaning oligocytes. Ego means fried egg appearance. Eggs come from chicken wire, capillary pattern, and calcification is also seen with all oligodendroglioma. Then you have the meningioma. Meningioma is coming from meninges with cells, arachnoid cells. Meninges are associated with PSA. Men are associated with PSA. Men for meninges and PSA, right? So P is going to be for psammoma bodies, which are laminated calcifications. S is going to for spindle cells, and A is going to be for arachnoid cell origin. So if you have any of this, arachnoid cell, spindle cell, psammoma bodies, you're going to think about meningioma. The next we have hemangioblastoma. Heme for erythropoietin production, secondary polycythemia. Angio means blood vessels. It's a blood vessel origin. Blastoma is associated with von Hippel-Lindau syndrome, which is von Harp-Lindau syndrome. The next is pituitary adenoma. It could be functional, non-functional. Non-functional give you mass effect headache. Functional, most commonly it's going to increase prolactin. Prolactin signs and symptoms are galactorrhea and menorrhea. Decreased libido in males and infertility and gynecomastia in males. Dopamine agonist is a treatment or transsphenoidal resection if dopamine agonists are not working. Less commonly, it gives rise to GH, growth hormone secreting tumor, which is somatotroph, corticotrophs, which releases ACTH, thyrotrophs, TSH, and gonadotrophs releasing FSH and LH. Lastly, we have schwannoma. Schwannoma, as the name suggests, is a Schwann cell origin, S100 positive Schwann cells. Here, if it's a unilateral, it's going to be, if it's unilateral schwannoma, it's called acoustic neuroma. And if it's a bilateral schwannoma, it is associated with NF2. It's going to affect this cerebellopontine angle, which contains a cranial 5, 7, and 8. When it affects the 8, it's going to give you tinnitus, unsteady gait, and hearing loss. And it's an actual palisading cells with verruca bodies. And that is all for primary adult tumors. Let's mention two extra that we have is the primary CNS lymphoma. I'm sure they're going to be mentioned somewhere else, so we'll just briefly touch here on it. So these primary CNS lymphoma, they will arise from the B cells, most commonly from diffuse large B cells lymphoma. So they are going to be positive for, if they're arising from B cells, they will be positive for B cell markers, which are CD20 and CD79A. They occur as a complication. Of Epstein-Barr virus in immunocompromised, meaning HIV/AIDS patient, right? And they are high-grade tumor with poor prognosis. High-grade with poor prognosis. And poor prognosis and poor response to chemo. Poor response to chemotherapy. Sinus symptoms are associated with areas involved in sinus symptoms are going to be your mental status change. One thing. Second thing, progressive focal neurological. So wherever the area is involved, you will have neurological deficit of that area. On biopsy, it's going to look like numerous immature lymphocytes. That's high yield. Numerous immature lymphocytes, which are basically the lymphoma cells, right? And in the CSF, you will see cystospin. Okay, now let's just review the whole thing, move on to the next one. So it's the primary, it is the, let me just change color here. It is the primary CNS lymphoma, starting from arising from B cells, which are going to be CD20 and CD79A positive, associated with EBV and immunocompromised, example HIV and AIDS, immunocompromised. This is these are high. It's in a high grade with poor prognosis and poor response to chemotherapy. Sinus symptoms are mental status change and a progressive focal neurological deficit wherever they're present. High yield point is on biopsy. There's going to be numerous immature lymphocytes, which are the lymphoma cells, and on CSF you will see cystospin. The next one is our let's just mention it here. That's the cavernous hemangioma, and you will see some cavernous hemangioma in your hepatic sections as well. But here is a little different. This is cavernous hemangiomas. They are vascular malformation, which are composed of cavernous, right? Abnormally dilated capillaries. So they're abnormal dilated capillaries separated by thin connective tissue, septa. These capillaries only have thin adventitia and lack of elastin fibers and smooth muscles. So this causes recurrent bleeding, which leads to, again, I said it's also in the liver too. So it causes bleeding in the brain, and because they're also in the liver, it's going to cause a bleed in the liver. When you cause the bleeding in the brain, it's going to cause neurological deficits plus seizures, right? When it's called intracerebral hemorrhage, right? And when the liver, and it's going to cause things in the liver, and we will talk about that when we do the liver. But again, let's just recall the whole thing. It's the cavernous hemangioma. Again, very high yield point is that you have the capillaries with thin adventitia with lack of elastin. So you have the capillaries, but they have the thin adventitia and lack of elastin fibers and smooth muscles. So they're prone to bleed. So there's a recurrent bleeding because you just have a thin smooth muscle layer with thin elastin fibers and thin adventitia. So you will have a recurrent bleed in the brain and the liver, and that's called a cavernous hemangioma. Okay, now let's talk about childhood primary brain tumor. These are relatively easy. You just got to remember a couple of facts with each one of them, and you're good to go with these. So the first one is, again, pleocytic astrocytoma arising from the astrocyte, as the name suggests. Astrocytes are all going to be GFAP positive. They are the most common primary brain tumor in childhood. It's usually well circumscribed in children, most often found in the posterior fossa, which is cerebellum. May be supratentorial, meaning above the tentorium, and cystic appearance with mural nodule, We will take a look at that picture. It's benign with good prognosis because they're the astrocytes origin, again, GFAP positive, bipolar neoplastic cells with hair-like projections associated with microcyst and rosenthal fibers, high-yield rosenthal fibers. What are rosenthal fibers? They're eosinophilic corkscrew fibers. So, excuse me, with the paleocytic astrocytoma, these are the rosenthal fibers. So just got to remember one thing here. Paleocytic astrocytoma, they are again, with the name suggests, astrocytes. So GFAP positive with rosenthal fibers. So somehow you got to know the rosenthal fibers for this astrocytoma, paleocytic astrocytoma. What are rosenthal fibers? They are eosinophilic corkscrew fibers. Let's take a look at picture B. Picture B here. Rosenthal fibers. They are the, you can see it here. They're the eosinophilic. Let's just go back. What is that? See, eosinophilic corkscrew fibers. Okay. What else is there? So wait. Rosenthal fibers. Where did you go? Okay, right here. Yeah, rosenthal fibers. On top of this, you got to know that they are the processes of astrocytes. They're eosinophilic corkscrew fibers. They are the processes of astrocytes because it's an astrocyte or rich astrocyte tumor, right? Of course, it's something has to be with astrocytes. And what else you might see? You will have hair-like projections as well. And it arises from, that's also common, the posterior fossa cerebellum. So cystic lesion with the nodule growing on it, on its wall. That's the mural nodule. Let's take a look at picture A. So if you take a look at picture A, it's a cystic lesion with a nodule growing on it. Okay. It's a cystic lesion with a nodule growing on its wall. It's a mural. You see, you have a cyst and then something is growing on top of this white surface. So it's called as mural. It's called as mural what? Mural nodule right here. Okay. So recalling this whole thing, here all you gotta know is pilocytic astrocytoma, GFAP positive astrocytes, and rosenthal fibers, which are the foot processes of astrocyte. The next one is the medulloblastoma. It is most common malignant brain tumor in childhood, commonly involves the cerebellum, can involve the cerebellar vermis. When you involve the cerebellar vermis, of course, you're going to have a cerebellar sign. So truncal ataxia will be there, can compress the fourth ventricle, can lead to non-communicative hydrocephalus, can lead to headache, papilledema. When it causes non-communicative hydrocephalus, of course, it's going to increase ICP, and that's going to cause headache and papilledema. Can send a drop mets to the spinal cord. That's drop mets, because it's, again, if you look at the whole thing, it is arising from commonly involves the cerebellum, which blocks the fourth ventricle. So it's very common that it's going to send all of that into CSF. And when it's sent to CSF, that's the drop mets. Okay. Form of primitive neuroectodermal tumor, PNET. High yield point is it's a homocyte rosettes, which are small, round blue cells surrounding central areas of neutrophil. So let's take a look at picture D. We see we have this small blue. We have these small blue cells. Right? Sheets of round small blue cells with increase in mitotic figures. Okay. What they were mentioning was small round blue cells surrounding central area of neutrophils. So let's take a look at that again. Central area, they are surrounding what? A central area. And that central area they're saying is a neutrophil cells. Why can't I zoom out? Okay, here is an area of neutrophil. Okay. It's a synaptophysin positive. It is a synaptophysin positive. That's also important. So for this one more important point is, so these PNET cells, they are going to surround the necrotic area, necrosis, central necrotic area, which is filled by neutrophils. And that is what is called the homocyte rosette. As you can see there, these are the rospetal type surroundings, right? And one of the things that you can just think about is medulloblastoma will send the roses, rose drops to the spinal cord from the cerebellum. So the important thing that we have to know for medulloblastoma is going to be that these are homocyte rosettes cells, which are rising from PNET and synaptophysin positive, and they will send the drops to the spinal cord, involving cerebellum and fourth ventricle. Moving on with ependymoma. Ependymoma is the most commonly found in the fourth ventricle, leads to non-communicating hydrocephalus, poor prognosis. Again, epen means ependymal cellular origin, which leads to characteristic perivascular pseudorosettes. Now, the top one was proper rosettes, meaning a proper rose type structure was there. Here you have a pseudo rosettes. Rod-shaped blepharoplasts, which are the basal ciliary bodies found near the nucleus. Let's take a look at pseudo rosettes, picture F. Here you can see picture F. We have the rosettes, but they are not proper centering. They are like this. Pseudo sort of rosettes. Okay. And perivascular. So all you got to know is this is ependymoma, meaning ependymal cells. Ependymal cells, again, perivascular on the side of the vessel. They will be perivascular pseudorosettes. Here's the vessel. You have a perivascular on the side of a vessel. You have a pseudorosette formation from these ependymal cells. And they are the rod-shaped basal ciliary bodies found near the nucleus and poor prognosis. So again, what is the common thing? Important thing here, we have to know ependymoma, ependymal cells, perivascular pseudorosettes. And because it's an ependyme, you already know it has to deal with some sort of ventricle, so fourth ventricle causing non-communicating hydrocephalus. The second last is, again, important one is craniopharyngioma, super easy, most common childhood supratentorial tumor. Calcification is commonly arises along the pituitary stalk, leading to compression of the optic chiasm, leading to bitemporal heminopsia. Again, if it's going to arise from the pituitary stalk here, it's going to compress on this optic chiasm. When it compresses on the optic chiasm, it's going to lead to bitemporal hymenopsia. And we also saw that in pituitary adenoma, right? But here we have to differentiate with this being it's a childhood tumor that is going to be a derivative of a Radke's pouch. If you see a Radke's pouch, you can right away think about craniopharyngioma. If there is a remnant of a Radke pouch, it is craniopharyngioma, which is an ectodermal origin. It is anucleate squamous cell, which are the ghost cells forming keratinous nodules with dystrophic calcification. Dystrophic calcification, let's take a look at picture H. So you have calcification depositions in the cells, calling it dystrophic calcification. And what is metastatic calcification? So dystrophic is whenever you have a bad tissue, you have calcification, meaning calcium deposition. That's the dystrophic calcification. What is metastatic calcification? Well, metastatic calcification, you have increased calcium and it deposits into normal tissues. And that's called metastatic. So dystrophic calcification, as the name suggests, dystrophic, bad tissue, meaning you have some tumor, something here. That's what's a bad tissue. Calcification, again, deposition of the calcium. Cholesterol crystals found in the motor oil-like fluid within the tumor. And that's also important to remember. So if you just recall what the how the craniopharyngioma would develop normally, so you have, if you recall, that you have diencephalon. Let me just write it here. Okay, so here, the Radke's pouch. So here's the way we should think about it. So the posterior, there is anterior pituitary, posterior pituitary. The posterior pituitary arises from diencephalon, which is arising from a neuroectoderm. The anterior pituitary, on the other hand, arises from the roof of mouth, and it travels and joins the posterior pituitary. And if this normal process does not happen, you have the remnant of the floor of the mouth, which is known as Radke's pouch, which is arising from the ectoderm. So you have the posterior pituitary arising from, let's just mention here, from neuroectoderm, and the anterior pituitary arising from surface ectoderm, because there's a surface, roof of the mouth, surface ectoderm. Diencephalon, the neuroectoderm. So, and then you will also have calcifications. First of all, let's take a look at it here. Anucleate squamous cells, which are the gold cells, forming keratinous nodules, meaning keratin nodules. These keratin nodules will give you motor oil-like fluid within the tumor cells. The motor oil is the brown-yellow fluid due to the vet keratin being present there. The signs and symptoms of craniopharyngiomas are going to be bitemporal hemianopsia. That's one thing. But again, you cannot make your anterior pituitary hormone, so you are going to have decrease in prolactin, decrease in growth hormone. If you have decrease in growth hormone within a child, so you are going to cause growth retardation within the children. And that's going to be all for craniopharyngiomas. The next is about pineal gland tumor. Pineal gland tumor is most commonly extragonadal germ cell tumor. Increased incidence in males. Presents with non-communicating hydrocephalus due to compression of the cerebral aqueduct. It leads to Perinaud syndrome, which is the compression of the dorsal midbrain, leads to triad of upward gaze palsy, convergence, retraction nystagmus, and light near dissociation. And this is the classic triad for Perinaud syndrome. So for pineal gland tumor, for example, pinealoma, this is most common extragonadal germ cell tumor in males, has a high incidence in males. And with the pineal gland, you could just think about anatomically, it's going to obstruct the cerebral aqueduct, causing non-communicating hydrocephalus, leading to Perinaud syndrome if it messes up with the MLF, medial longitudinal fasciculus, which will cause three things: triad of upward gaze palsy, nystagmus, and light near dissociation. Pineal gland tumors are similar to testicular seminomas because they most commonly also involve the pineal gland, causing pinealoma. And less commonly, they would involve anything else, for example, ADH, diabetes causing diabetes insipidus, and all other endocrinopathies. Okay, now let's review these childhood brain tumors. Pilocytic astrocytoma is astrocyte origin with a GFAP positive for sure because it's an astrocyte. High yield is rosanthal fibers, which are eosinophilic corkscrew fibers, which is rosanthal fibers. And it's going to appear as cystic appearance with a mural nodule. So you have a cystic appearance. It appears as a cyst with a mural nodule up top, and specifically in the cerebellum. cerebellum in a child, posterior fossa. Then you have the medulloblastoma. Medulloblastoma is associated with PNET. These cells, they have the proper palisading. They form a rosette sign with the central necrosis. So these rosettes are the Homer-Wright rosettes. So roses have been sent to drop in the CSF. So you will have a drop met in the CSF from the cerebellum to fourth ventricle, from fourth ventricle to drops into CSF. And that's with the medulloblastoma. Then you have the ependymoma. Ependymoma is again ependymal cells origin. With the ependymal cell origin, it's ependymes or the ependymal cells, or they line the ventricles arising from the fourth ventricle, causing non-communicating hydrocephalus. If you think about all of them, they're all causing non-communicating hydrocephalus. So just imagine this thing, because you're trying to block with a tumor. If you were to cause something, it's going to be non-communicating hydrocephalus, right? With the ependymal cells, they are the perivascular pseudorosettes. So instead, they are the perivascular. So you have a vascular territory in the center, and you are the perivascular. You have the pseudorosettes, and we can see the picture right here. You have the vascular territory, and you have the pseudorosettes, and this is seen with the ependymoma. Then you have the craniopharyngioma. They are the remnant of Radke's pouch. Radke's pouch have the keratin leading to motor-like fluid, and it also leads to deposition of the calcium, dystrophic calcification. Causes bitemporal heminopsia, but also decrease in all the pituitary hormones. So all those symptoms are also going to be appear. Then you have a pineal gland tumor. Most commonly, it's the extragonadal germ pseudo, because they're similar to testicular seminomas. Again, it causes non-communicating hydrocephalus because it's going to block the cerebral aqueduct. Causes Perinaut syndrome, leads to triad of upward gaze palsy, nystagmus, and light near association. And that's going to be all for childhood brain tumors. Okay, now let's take a look at herniation syndromes. Well, herniation syndromes, they occur. First of all, we have to know why would we have the herniation? Well, they would occur if we have an increase in ICP, intracranial pressure. And why would we have an increase in ICP? A lot of causes. Some of them are if you have a mass effect. Mass effect can lead to increase in ICP. Mass effect will develop due to a tumor or due to hemorrhage. The second thing you can think about is cerebral edema. And that edema could develop due to either the stroke or trauma. And lastly, if you have hydrocephalus, you're increasing the ICP. So when you increase when you increase or expand the volume, for example, it forces the brain tissue. It forces this brain tissue through the weak points. And let's talk about what are the weak points here. So first, we have the Fox cerebri. We have Tentorium cerebelli. So looking at the first here, we have this cingulate subfalcine herniation under the Fox cerebri. So we have a Fox cerebri subfalcine under the falcine. Under the Fox cerebri, there is the herniation. So you can see these cingulate is herniating under the Fox cerebri. And the problem was, what is it going to cause? Well, it is going to cause ACA compression, anterior cerebral artery compression. So if you think about it, when you have ACA compression, that's going to cause contralateral lower extremity weakness, for sure, sensory and motor, right? If affecting the dominant hemisphere, can cause arcuate fasciculus compression, which leads to aphasia. And again, arcuate fasciculus was which was connecting the Broca's to the Wernicke's area, right? So that can lead to aphasia, right? So here's a simple thing: when you have a herniation of cingulate going toward the other side, it's going to compress ACA. With the ACA, you know it's going to cause contralateral lower extremity weakness. But on top of this is the dominant hemisphere, then you were thinking about aphasia. The next thing is going to be about central downward transtentorial herniation. So here's the central downward transtentorial herniation. It's going to lead to displacement of the brainstem. When you displace the brainstem, that's going to cause a rupture of the paramedian basilar artery branches. When the paramedian basilar artery branches are ruptured, it leads to direct hemorrhages. They're fatal. Direct hemorrhages. They're usually fatal. Okay, now the next is uncal transtentorial herniation. That's point 3 here. Let me erase this part. So there's a transtentorial herniation of the uncus. Uncus leads to medial, it's in the medial temporal lobe. Okay. Earlier herniation causes ipsilateral blown pupil because you're affecting the ipsilateral unilateral cranial nerve 3. You're compressing that. And contralateral hemiparesis. Okay. But late herniation can lead to coma and Kernohan phenomena. What is Kernohan phenomena? If you take a look here, so let's just review this part, is the uncal herniation. Earlier herniation is just going to herniate just the same side. So it's going to cause ipsilateral blown pupil because it's compressing the ipsilateral unilateral CN3, right? And it causes contralateral hemiparesis because it is compressing the corticospinal tract. But late, now important point is earlier and late things. So earlier is an ipsilateral. Late, let's change color. Late herniation leads to coma and Kernohan phenomena. Now, what is Kernohan phenomena? That instead that it goes and compresses its own side, but it goes and compresses the other side, and that's the area that is known as Kernohan notch. When it compresses on the Kernohan notch, now it's known as Kernohan phenomena, which is ipsilateral hemiparesis, which is going to be opposite. Now, if you look, there was a contralateral hemiparesis. Here you have ipsilateral hemiparesis. There was an ipsilateral blown pupil. Here you have a contralateral blown pupil due to contralateral cerebral peduncle being affected, being compressed, and CN3 being compressed against the Kernohan notch. So this is all about it. So the easy way to remember all of this is if you have uncal herniation, you have an early and late. With an early, you should get an ipsilateral blown pupil. With the late, you are going to get contralateral blown pupil. If you have an ipsilateral blown pupil, the second thing is going to be opposite, which is going to be contralateral hemiparesis. And if you have a late complication, which is known as Kernohan phenomena, you have a contralateral blown pupil. So here you're going to have an ipsilateral hemiparesis, and that's how you differentiate these two. Okay, but in all the case, you just got to know, okay, one thing is uncal herniation towards the side is going to cause ipsilateral CN3 palsy, ipsilateral blown pupil. But if it goes, the uncal herniation goes and affected the other side, that's the Kernohan notch. When you compress that Kernohan notch, you are going to be giving the opposite side. You're affecting the opposite side, which causes all these other sign symptoms. The last one here we have is the cerebellar tonsil herniation into the foramen magnum. So here's the cerebellar tonsil. It's herniating into the foramen magnum, which leads to coma, death. Because again, if you think about it, all the respiratory centers, all of the cardiovascular centers, they're here, right? So when you herniate that into foramen magnum, when you herniate the cerebellum into the foramen magnum, you're just causing coma, death, because of herniation of the brain stem, which compresses the brain stem. Okay. And if you have upward herniation, let's say upward herniation of cerebellum, which is not mentioned here. So if you have an upward herniation of cerebellum, that's just going to cause cerebellar signs, which are going to be ataxia and nystagmus. Okay, and that's going to be all for herniation syndromes. Let's actually review this quickly before we move on. So here we have simple things, and super easy. All you have is you have increase in pressure, ICP's increase. That's gonna put the pressure on the brain to herniate through the weak points. Okay, so the first is the cingulate herniation under the falx cerebri. The first one, that's going to cause ACA compression, which is going to give you lower extremity weakness. And if it's the dominant hemisphere, it's going to cause aphasia because compression of the arcuate fasciculus. The second is central downward transentorally herniation, this part. And that's going to displace your brainstem, which causes basilar artery to rupture, causes Durette hemorrhages. And you can see Durette hemorrhages being here. Durette hemorrhages. Okay, the third thing is all about the uncal herniation. Uncal herniation is this uncus. If it goes on the unilateral side, which is seen in earlier herniation, is going to cause ipsilateral compression of CN3, causes ipsilateral blown pupil and contralateral hemiparesis. But on the later hand, what it's going to do is going to compress the other side, which is the Carnohan notch. When it compresses the Carnohan notch, that's called Carnohan phenomena, which causes ipsilateral hemiparesis and contralateral blown pupil due to contralateral peduncle being affected and compressed against the Carnohan notch. The last part here is cerebellar tonsil herniating through the foramen magnum. It's going to compress the brainstem, which has all the centers, so it's going to cause coma and death in that patient. And that is all for herniation syndromes. Okay, now let's talk about motor neuron signs. In here we have an upper motor neuron lesion signs and lower motor neuron lesion signs. Importantly, before we talk about that, let's just take a look at some mnemonics. Lower motor neurons will give you everything being lowered. You will have a decrease in muscle mass, tone, reflexes, toes. With the upper motor neuron, everything is up. Tone, reflexes, toes. Fasciculation is muscle twitching. Positive Babinski is normal in infants. So let's take a look at each one of these things. Now, if there is a weakness, you will have weakness with both the upper motor neuron and the lower motor neuron lesions. Atrophy is only seen with the upper motor neuron lesion. Wait, my bad. It's only seen with the lower motor neuron lesion. And why is that? Because there is a denervation to the muscle. And that is an important concept. When you denervate a muscle fiber or a muscle group of muscles, they are going to go into atrophy. Denervation of the muscle fibers. Fasciculations are going to be positive with the lower motor neuron lesions. What are fasciculations? They're the twitching of the muscles. Reflexes are lowered in the lower motor neuron lesion and are hyperreflexion, upper motor neuron lesion. Tone is also increased and tone is decreased in lower motor neuron lesion. Then you have Babinski. Babinski is only going to be positive with upper motor neuron lesion. And what is Babinski? Babinski is when you have, so let's just talk about Babinski here. You can test it by stroking the plantar surface of the lateral foot. So let's say this is the foot. You when you stroke the lateral surface of this lateral part of the plantar surface of the foot, from heel all the way to the big toe, what's going to happen is normally it's going to give you plantar flexion in adults we're talking about, not in infants. Plantar flexion. And what is plantar flexion? That they will go down, like they will bow down, sort of a say. But what's going to happen with Babinski is that instead of plantar flexion, they will fan out. So they are going to like fan out. Okay, and that's called dorsiflexion, upwards. They will fan out upwards. So great toe would bend upward. That's the dorsiflexion. Okay, so normal is plantar, abnormal is dorsiflexion. And then you will say, okay, because when you have dorsiflexion, you call it positive Babinski, and that is seen with only with the upper motor neuron lesion. So it's in other words, also seen as fanning of the toes. Fanning of the toes as they're gonna go up. Okay. So that is your Babinski sign. It is normal in infants, but abnormal in adults. But with upper motor neuron lesion, it's going to be positive. So spastic paralysis is going to be positive for upper motor neuron lesion. And what is a spastic paralysis or spasticity? Spasticity is when you have increased resistance to passive movements. That you can't have a passive movement. You try to move the muscles, you can't, because there's an increase in tone. You have increase in tone, it's going to cause spastic paralysis, paresis, spastic paresis. Flaccid paralysis, on the other hand, is all about flaccid, meaning it's relaxed. It's it's like floppies, relaxed muscles, right? So let me just write. Flaccid is relaxed, like floppy muscles. Spastic is all about stiff, rigid muscles. Now, clasp knife spasticity is simple as the muscles are overactive. It's seen with the upper motor neuron lesion. Overactive. So, for example, excuse me. For example, if you have a passive movement, with the passive movement, there's an initial resistance because, again, you have increase in tone, spastic paresis. But after the initial resistance, then there's a sudden release. And that's called clasp knife spasticity. Okay, let me just make simple sense. We are looking at spastic. Spastic is all about upper motor neuron lesion, right? Clasp knife spasticity is when you try to have some passive movement. At first, you will have a resistance to that. Secondly, after some resistance, then there's a sudden release, as if like you took your foot off the brakes. There's sudden release, and that's called clasp knife spasticity. Okay. So let's just recall this part. And again, upper motor neuron lesion is going to be seen anywhere from your CNS to the spinal cord, anywhere. And lower motor neuron lesion is seen with the spinal nerve. So as soon as the nerves go out of the spinal cord, if you have a damage there, it's going to cause lower motor neuron lesion. Okay, and that's just a rough estimate of things. But what you are looking at for the lower motor neuron lesion is the spinal nerves damaged or something happened to them, or the cranial nerves, CN, from 3 to all the way to 12. Okay, and that's pretty much what we have. So let's just recall this. We said with the lower motor neuron lesion, we have everything lowered. So that there is going to be muscle weakness, and that muscle will be atrophied due to denervation, right? Fasciculations will be there, which are muscle twitching, also occur due to denervation of affected muscles. Small group of muscles twitching or contractions is called twitching, right? You would have decrease in reflexes, hyporeflexia or areflexia. Again, less than 1 plus. Okay, that's the reflexes. Normal reflexes 2 plus. Anything above 2, let's say anything equal to 3 or more than 3 is known as hyperreflexia. Anything less than or equal to 1 is called hyporeflexia. 0 means areflexia. 2 is normal. When they say 2 positive reflexes, they are saying normal reflexes. Tone is also low. And you have just a flaccid paralysis in which you have just relaxed, floppy muscles. So with lower motor neuron, everything is lowered. Hyperreflexia, low tone. With the floppy, there's weakness, there is atrophy, but there is fasciculations. That's the only thing that is there, right? With the upper motor neuron lesion, you are going to have, there is no atrophy. What you are going to have, there's going to be increase in tone, increase in spasticity. What is spasticity? Again, stiffness or rigid muscles, spastic paralysis, and calf knife spasticity, which means first you have resistance and then you're going to let it go and have a sudden release. That's called calf knife spasticity, with Babinski being positive and upward. So again, if you think about it, upward going toes, which is dorsiflexion, fanning out, right? Upward going toes, and hyperreflexia. Simple thing seen with the upper motor neuron lesion. And that is going to be all for this one, this motor neuron signs. Okay, now let's talk about spinal cord lesions. Before we actually dive into all the lesions, we got to know the normal, right? So here, the normal of spinal cord is going to be, let's just mention the names here of how the dissection of a spinal cord, what are the structures. So we have here, we have your anterior horns. So anterior horns. And behind the anterior horns, all are we going to get is this all area is the dorsal root ganglia. And what is entering into the anterior horn is your dorsal column, which isn't, but here is something called as dorsal column, which we will see in some of the lesions. For example, in tabes dorsalis. So this is the dorsal column. Dorsal column. We have a couple more things. Just on the lateral side of it, we have lateral side, we have corticospinal tract running here. Corticospinal tract. And to most lateral, we have spinocerebellar tract. Spinocerebellar tract. And if there is anything that we need, we'll talk about that when we see that. Okay, so let's now dive into the first disease we have here is called the poliomyelitis. Poliomyelitis is a destruction of the anterior horns by poliovirus, right? Destruction of the anterior horns, which are right here. That poliovirus is it has a fecal oral transmission, replicates in the lymphoid tissue of the oropharynx and small intestine, leads to spread into the CNS via bloodstream. From fecal oral all the way to oropharynx to small intestine, then via the bloodstream to CNS. It causes a lower motor neuron signs, which in here it's going to be asymmetrical weakness, and symptoms of viral meningitis, fever, headache, neck stiffness. Respiratory muscle involvement leads to respiratory failure. CSF would show increase in WBCs, lymphocytic pleocytosis, and slight increase in proteins with no change in CSF glucose. Because it's a virus, why would we have a change in glucose, right? But we have increase in proteins and increase in WBCs for sure. Poliovirus can be isolated from stool or throat secretions because it's coming from fecal route and replicates in the lymphoid tissue in the oropharynx. So you can for sure isolate it in stool or throat secretions. Now, importantly, if you just look here, it affects, what do we say? It leads to destruction of these anterior horns, but it is asymmetrical because it is only affecting one more than the other. If you look here, if you look, it's not symmetrical destruction. So that is why there is an asymmetrical weakness and lower motor neuron signs. And what were the lower motor neuron signs? Everything lowered. Low reflexes, low tone, fasciculations, floppiness, muscle weakness, all of that, right, is all lower motor neuron signs. So now what did we learn? A good point here. If you are going to destroy this area, which is the anterior horn, you are going to get lower motor neuron lesion sign symptoms. Here is asymmetry because there is an asymmetric destruction. Now looking at the next one is the spinal muscular artery, SMA. It's a congenital degeneration of again anterior horns. But here, if you look at the destruction, it's symmetrical. So you're going to have a symmetrical weakness, lower motor neuron signs with symmetrical weakness, because it's again, it's a congenital degeneration of anterior horns. It is autosomal recessive, SMN1 mutation, which encodes for survival motor neuron protein 1 mutation, leads to defective SNRNP assembly. Now, SNRNP assembly is also important. Now, they might not say SNRNP assembly. They might tell you the full name. So what is an SNRNP? It's a small nuclear ribonucleoprotein. Small nuclear ribonucleoprotein, SNRNP. Okay. And that is, again, important. And that is important because SNRP, they are dealing with splicing. So it's a defective splicing. Okay. That leads to lower motor neuron apoptosis. It's a spinal muscular atrophy type 1 is the most common, which is called Wernig-Hoffman disease. Okay. Lower motor neuron signs only, symmetrical weakness, floppy baby, again, floppiness, fasciculations will be there, flaccid paralysis, the floppiness, right? With marked hypotonia because lower tone flaccid paralysis. Again, you don't have to even look at these because it's all lower motor neuron sign symptoms. All you got to know is lower motor neuron sign symptoms with symmetrical weakness, meaning bilaterally you're going to get that weakness. Okay. And that's what we have. One important also point that you have to just mention when comparing polio, first of all, comparison-wise, we have asymmetrical weakness. Over here, we have symmetrical weakness. Or there is going to be an infectious etiology, which is polio, that destroys the anterior horns. Here is the congenital genetic problem, SMN1 gene mutation, that leads to defective splicing. SNRNP assembly causes lower motor neuron apoptosis. So congenital, infectious. Okay, and then you have what else? Yeah, pretty much that's all we have for these two. Moving on with the ALS. Amyotrophic lateral sclerosis. It's a combined upper motor neuron and a lower motor neuron degeneration. So you're knocking out your anterior horns, and you're also knocking out your corticospinal tract, which is going to give you an upper motor neuron lesion. So let's take a look. Upper motor neuron lesion, corticospinal, corticobulbar tracts, and your lower motor neuron lesion, brainstem, spinal cord, anterior horn damage. It's idiopathic. Familial form, less common, may be linked to SOD1 mutation, which encodes for superoxide dismutase 1. That's high yield. SOD1, superoxide dismutase 1 mutation. Okay. And ALS is also called Lou Gehrig disease. Okay. So when you knock out your lower motor neurons, you are going to get those signs, and also you're going to get upper motor neuron signs. So let's take a look at each one of them. So lower motor neuron signs are flaccid limb weakness, fasciculation, atrophy, bulbar palsy. Bulbar palsy is dysarthria, dysphagia, tongue atrophy, where then upper motor neuron signs are spastic limb weakness, hyperreflexia, clonus, pseudobulbar palsy. That is, again, dysarthria, dysphagia, emotional lability instead of tongue atrophy, no sensory or ball bladder deficits. So their sensations are intact, ball bladder intact. Okay. It is fatal, most often from respiratory failure. The patient would die with respiratory failure. Treatment is also high yield. It's called riluzole for Lou Gehrig disease. Like, look at that, Lou Gehrig, riluzole. Edaravone, which is a free a radical scavenger, which leads to slow functional decline in these patients. Okay, so in ALS, we will also see a couple other features. For example, let's start with the first one. With ALS, the classically scenario is going to be the middle-aged patient who's going to be presenting with a middle-aged patient who's going to present with motor neuron damage. It's going to affect most commonly the cranial nerve that are affected with the motor symptoms only, no sensory deficits here, right? So motor neuron disease with no sensory, this is high yield. So middle-aged patient with a motor neurons being affected, no sensory deficits. If you look here, no sensory deficits. The cranial nerves that is going to be that are going to be affected are most commonly are CN5, 9, 10, and 12. And when you knock out your anterior horns, there's going to be seen as thin anterior roots, and because you're knocking out your corticospinal and corticobulbar, that's going to cause atrophy of the pre-central gyrus. Okay. And this SOD mutation, what was normally SOD was doing was it was encoding for superoxide dismutase. If you recall superoxide dismutase, then you can think, okay, it is used in the removal of free radicals, superoxide dismutase. So when you have a mutation in superoxide dismutase, it's going to cause free radical damage, and that's going to damage neurons. When you damage the neurons, you have glutamate release from these neurons causes excitotoxicity, meaning more and more damage to the neurons. So that's why the treatment is riluzole, in which you are going to decrease glutamate release from the neurons, and this riluzole will decrease the progression of disease. Now, how do we gauge the progression of disease? It is done by the vital capacity. So because you're knocking out your lower motor neurons, you are going to get diaphragmatic atrophy, which is going to be seen as respiratory failure. And that's diaphragmatic atrophy will cause decrease in the vital capacity. And this decreased vital capacity determines the prognosis of the disease. Where is the prognosis of the disease? The next thing is, if you take a look at here, we have bulbar, which is an upper motor neuron sign, and a pseudobulbar, which is a lower motor neuron sign. The difference is with the bulbar palsy, it is affecting the actual cranial nerve. That's why it's called bulbar palsy. If you look at the symptoms, they're almost the same, except you have emotional lability and tongue atrophy, which not much difference there. So the name is only different because in bulbar, you're actually attacking, you're actually destroying the cranial nerves, versus pseudobulbar, you are damaging the corticobulbar tract. Corticobulbar tract that causes pseudobulbar palsy, not the nerve, but the corticobulbar tract. Now here, both of them are giving you dysphagia. So upper and lower motor neuron are going to give you dysphagia. So dysphagia, what's going to happen is a patient will undergo aspiration pneumonia. With aspiration pneumonia, there's again going to be respiratory failure, and this is the leading cause of death in ALS patient. With the remaining, with the neuronal damage, the remaining neurons will have bunina bodies, or however you want to call it, bodies will be present in the neurons, in the remaining neurons, which are just your periodic acid stain positive, past positive material within the rest of the neurons. And that's and one more last thing is zinc. Zinc is a cofactor for normally. So zinc is a cofactor for SOD, which is superoxide dismutase, and that is going to be all. So let's just review the whole thing and move on to the next. ALS, let's just do it here. ALS, where's the, here. ALS, it's a middle-aged patient with an upper motor neuron and a lower motor neuron damage, because when you knock out your anterior horn, you're going to get lower motor neuron damage. You knock out your corticobulbar, corticospinal tract, you are going to get upper motor neuron lesion. But importantly, no sensory or bowel bladder deficits. You can differentiate this thing versus something known as syrinx, right? Or syringomyelia. With syringomyelia, if you know the syrinx, when it enlarges, it's going to knock out the anterior horn, and it could enlarge and also knock out your corticospinal tract. But it will give you also sensory deficits, like pain and temperature will be out. But here, you have no sensory deficits. And again, it's just a thing to remind. Other than that, everything is pretty high yield here. With the ALS, there is a mutation. There is a mutation in the SOD, which is the superoxide dismutase. What cofactor is zinc. When you have a mutation in SOD, there's a lot of free radical formation that damage the neuron. Damaged neuron will lead to a lot of glutamate release, lead to excitotoxicity, meaning damaging more and more neurons. So we got to decrease that glutamate by giving riluzole, and that is going to decrease the progression of disease. Okay, we have upper motor neuron symptoms and lower motor neuron symptoms. All of them are going to be present here. It's going to affect cranial nerve 5, 9, 10, and 12, and you will have thin anterior roots because you knocked out the anterior horn, and you're going to have an atrophy of the precentral gyrus because of the loss of the corticospinal tract. And it is usually fatal by respiratory failure. Aspiration pneumonia, one of the causes that causes respiratory failure due to dysphagia. There's an aspiration pneumonia which causes respiratory failure and death. With the lower motor neuron lesion leading to atrophy, right? So diaphragm, when it hits the diaphragm, it's going to cause diaphragmatic atrophy. That's going to cause decrease in a vital capacity. That decrease in vital capacity determines the prognosis of Lou Gehrig disease, which is ALS. And that is going to be all for ALS. Okay, now let's talk about tabes dorsalis. Well, tabes dorsalis is affecting the dorsal column here, dorsal column, and it's affecting the dorsal root ganglia, right? So, there's a, let's read now. There's a degeneration, demyelination of dorsal columns, and the roots by Treponema pallidum in tertiary syphilis. So again, we're saying there is a demyelination, degeneration of dorsal column and the ganglia and the roots, dorsal root ganglia, right, by tertiary syphilis. It causes progressive sensory ataxia, which is impaired proprioception, poor coordination, which leads to a positive Romberg sign, and an absent DTRs. Associated with shooting pains, Argyle Robertson pupil, and Charcot joints, high yield. So let's talk about each one of them. Now, when we knock out the dorsal column, let's just mention it here. When we knock out let's actually do a simple way and right here, dorsal column and dorsal root ganglia. When we knock out the dorsal column, we are going to have a loss of proprioception, vibration, fine touch sensation. And we knock out the dorsal root. Wait, I think I did an opposite. When we knock out the dorsal column, which is not this one, but this one. This is dorsal column. And this is dorsal root ganglia. Okay, dorsal column is going to give you all that, that proprioception, all the dorsal column sensations are out, right? And here's your dorsal column, right? And the dorsal root is going to give you, if you knock out your dorsal roots, you're just going to have loss of DTRs, which are your deep tendon reflexes. Again, loss of DTRs is lower motor neuron lesion. Loss means areflexia, right? So with the Tabes dorsalis, it's a late manifestation. It's a late manifestation of tertiary syphilis, which is also known as a neurosyphilis, which causes progressive degeneration caused by T. pallidum, okay, which is a spirochete. Okay, and this is classically seen in patient with HIV, STIs, homosexual patient. They will have difficulty walking, but their motor power in all extremities is 5x5. They have difficulty walking because you knock down your dorsal column, your loss of proprioception, vibration, and fine touch. That just causes poor coordination, and that's why you can't walk. But the power is normal, 5x5 power. They will have a wide-based gait, again, due to knocking out of this dorsal column. And because of tertiary syphilis, you can have a shooting pains. Shooting pains are the lancinating pains, which are sharp, stabbing, episodic pains. So shooting pains are just episodic pains. With Argyle Robertson people, again, this is all with syphilis, with tertiary syphilis. Shooting pains, Argyle Robertson people. In Argyle Robertson pupil is all about that they have small irregular pupil that would fail to constrict. They would not constrict when they will fail to constrict to light. So they will not constrict to light. And but there is normal accommodation. But normal accommodation is normal. Okay, that's Argyle Robertson pupil, meaning constriction of the pupil. There are already small pupils that will not constrict more to the light. Okay, and that is there. On top of that, you will also have neurogenic urinary incontinence, Charcot joints, and neurogenic urinary incontinence will also be seen with Tabes dorsalis. So here, let's just review important details here. Let's change color. So we're going to have our dorsal column that's going to be destroyed and roots are destroyed. When the dorsal column are destroyed, it's called sensory ataxia, and that's going to be positive Romberg. Okay, and when the roots are destroyed, it's called absent DTRs. And with the tertiary syphilis, is the shooting pains, Argyle Robertson pupil, and Charcot joints neurogenic urinary incontinence. Okay, you can run some tests on these patients. They will have a positive VDRL, and a lumbar. Let's just write them as well. Positive VDRL, and a lumbar puncture would show mild lymphocytic pleocytosis on CSF analysis. Okay, let's move on to the next part, which is subacute degeneration, subacute combined degeneration. Here, all we have is subacute combined degeneration is due to vitamin B12 deficiency. So if you look, what is destroyed is we have destruction of the dorsal column, and we also have destruction of the corticospinal tract. And which they haven't colored here is the other one, which is called spinocerebellar tract. Spinocerebellar tract. So let's take a look. So here we have a demyelination of, again, spinocerebellar right there, corticospinal, and dorsal column. Three things are just destroyed with vitamin B12 deficiency. So it's going to cause ataxic gait, paresthesias, impaired proprioception vibration sensation, which causes positive Romberg sign and an upper motor neuron sign. Which are, you already know, everything is going to be high with spastic paresis in legs and hyperreflexia and positive Babinski. Okay, so now let's just take a look at what's causing what, right? So DEC, when you knock out your dorsal column, it's going to give you impaired proprioception, vibration sensation, and positive Romberg. When you knock out your corticospinal tract, is going to give upper motor neuron signs, and spinocerebellar tract is going to give ataxic gait. Okay, and that is going to be how everything is affected. With this upper motor neuron signs, it's called combined degeneration, because you have an upper motor neuron signs with a dorsal column being affected, and that's a combined degeneration. So you have a combined myelin / axonal degeneration. In the ascending and descending column. So in the ascending one, you have a problem in the dorsal column, and in the descending one, coming from the top towards the spinal roots and all, is the corticospinal tract. The descending of these corticospinal tract problem, that's called combined degeneration. One high yield point about all of this is that vitamin B12 deficiency leads to increase in MMA levels. And that increase in MMA levels leads to all the myelin abnormalities and demyelination. So here, demyelination, increase in MMA causes demyelination of your SCD. So here's the mnemonic. The mnemonic is SCD, meaning subacute combined degeneration. And here's the mnemonic that goes to spinocerebellar tract, SC for corticospinal tract, D for dorsal column, all three out in the SCD due to vitamin B12 deficiency. Moving on with the sort of a last one here is called anterior spinal artery occlusion. So anterior spinal artery, ASA, gets occluded. ASA is right here. Okay, it is supplying to all this area. When it gets occluded, you are going into infarction in all this area, right? So let's take a look. You have a spinal cord infarctions sparing only where dorsal column, sparing only where dorsal roots, right? So sparing the dorsal horns and dorsal column. Watershed areas in the mid-thoracic ASA territory, as the artery of Adam Kievic supplies the ASA below T8. Can be caused by aortic aneurysm repair. Presents with upper motor neuron signs below the lesion, that's important, which is the corticospinal tract, and lower motor neuron sign at the level of lesion, which is the anterior horn, and loss of pain, temperature, sensation below the lesion, and that is due to spinothalamic tract. So the only sensations here we have intact are going to be the dorsal column and dorsal root, for example, the vibration, proprioception, fine touch, loss of all but these, sparing the posterior column, with the patient here is going to have a bilateral paralysis below lesion. So that's actually important. You have an upper motor neuron lesion, upper motor neuron sign below the lesion, and also loss of pain temperature below the lesion because of spinothalamic tract. But anything that is at the level of lesion is about lower motor neuron deficits. Okay, this is all due to the fact that ASA supplies all this area and PSA supplies the remaining area. And here we have the occlusion of the ASA, commonly caused by aortic aneurysm repair. Okay, and that's going to be all for ASA, anterior spinal artery occlusion. All right, now let's review the whole spinal cord lesions quickly. So spinal cord lesions, first of all, we have the poliomyelitis. We are knocking out the anterior horns asymmetrically. So we're going to have asymmetrical lower motor neuron signs. In poliomyelitis is a fecal-oral route transmission, which goes and replicates into the lymphoid in the oropharynx, and then it goes into intestine. From there, it goes into the bloodstream and gets into the CNS and causes the destruction of the anterior horns. Okay, this is infectious destruction of anterior horns. Here, because it's infectious, what we are going to have is increase in WBCs in CSF and increase in protein, but no change in glucose because of virus. Poliovirus can be isolated in the stools and in the throat secretions. Other than that, you have a lower motor neuron lesion. The most important thing is respiratory muscle involvement leads to respiratory failure. Okay, compare this with spinal artery atrophy, SMA. Poliovirus was infectious etiology. SMA, spinal muscular atrophy, is a congenital degeneration of the spinal horns, anterior spinal horns, which are due to SMN1 mutation, which encodes for survival motor neuron protein. That SMN1 mutation leads to defective SNRNP, which is spliceosome. So it's going to be a defective spliceosome, which causes lower motor neuron apoptosis. Type 1, SMA type 1 is called Wernicke-Hoffmann disease. It's going to give, again, same thing as the top one, but it's symmetrical weakness of a lower motor neuron lesion with a floppy baby hypotonia and tongue fasciculation seen with lower motor neuron lesions. The next is all about ALS, amyotrophic lateral sclerosis. It is a combined upper motor neuron and a lower motor neuron lesion, upper motor neuron being corticospinal tract and corticobulbar being affected, which are here, and lower motor neuron being spinal cord, anterior horn being affected in the spinal cord and the brain stem, which are here. It is linked to SOD mutation. SOD is a superoxide dismutase, which normally would decrease the free radical formation, but here, because you have a mutation in SOD, the SOD superoxide dismutase would not be able to work, causing increase in free radicals. Free radical would damage the neurons, and damaged neurons will lead to increased release of glutamate, causing more cytotoxicity. It's called glutamate excitotoxicity, causing damage to more and more neurons. And to decrease that glutamate release from the neurons, we want to give a treatment as riluzole. Riluzole is a mnemonic here because it's also known as Lou Gehrig disease. So we said it's a combined degeneration, so you have upper motor neuron signs and a lower motor neuron signs. Both are going to be present. With the respiratory failure, most common cause of death, how this respiratory failure started, because with the dysphagia, you will have, the patient will undergo aspiration pneumonia, recurrent aspiration pneumonia causing respiratory failure, causing death to the patient. With the lower motor neuron lesion, you are going to affect the diaphragm. When it hits the diaphragm, it's going to cause decrease in vital capacity. Vital capacity tells the prognosis of disease or progression of disease. Okay, and ALS is most commonly seen in a middle-aged patient and it's going to affect the cranial nerve 5, 9, 10, and 12. and you have atrophy of the anterior horns and atrophy of the presagittal gyrus. Okay, the remaining neurons will have Bunina bodies, which are PS positive material, periodic acid sustained positive material within the neurons. And lastly, here we have no sensory or deficits. In ALS, we will have no sensory deficits, and bowel and bladder are absolute normal. Compare this with a syrinx or syringomyelia, in which case if it expands, it's going to hit anterior horn, and when it expands more, it's going to hit the lateral corticospinal tract, again giving upper and motor neuron deficits. But that will also give you a sensory deficit in pain and temperature. But again, it's only going to be in the upper limb, sort of like shawl distribution of the upper limb, right? Let's talk about now tabes dorsalis. Tabes dorsalis, it's due to tertiary syphilis, neurosyphilis, which is going to degenerate and demyelinate the dorsal column and the dorsal root ganglia. When you hit the dorsal column, you're gonna have a loss of proprioception, and leads to poor coordination and Romberg sign positive. Right? When it hits the dorsal root, it's going to give you loss of deep tendon reflexes, which is the lower motor neuron lesion, right? Loss of DTRs. With the syphilis itself, it's going to cause shooting pain, which are episodic lancinating pains, which are sharp stabbing pains. Argyll-Robertson people, that the people are already constricted, they will not constrict more to the light, and incubation is normal, and Charcot joints. And on top of that, you will also have neurogenic urinary incontinence. High yield tertiary syphilis, tabes dorsalis. It is seen with, because it is tertiary syphilis, is seen with HIV, STIs, and homosexual patients. The patient will be difficult to walk because they don't have proprioception, but the power in the muscles are 5x5, normal muscle power. Wide-based gait and absent DTRs is classically seen. Okay, then you have this subacute combined degeneration. It is due to vitamin B12 deficiency, which causes increase in MMA. That causes myelin abnormalities that causes demyelination of all three things, which are spinocerebellar tract, which is going to be here, corticospinal tract, which is right here, and dorsal column, which is all the way through the back. So when you knock out your dorsal column, again, you're going to get impaired position, vibration, sensation, and positive Romberg. When you knock out your corticospinal, it's going to give you upper motor neuron signs. And spinocerebellar tract is just going to give ataxic gait. The mnemonic is SCD, vitamin B12 deficiency. So spinocerebellar, S, C for corticospinal, D for dorsal root column, SCD, due to vitamin B12 deficiency. Then lastly, we have this ASA occlusion, anterior spinal artery occlusion, and that is it supplies the blood to all the anterior parts. So all the anterior parts are going to go into infarction. So spinal cord infarction, because but you're only sparing the dorsal column because that is supplied to the posterior spinal arteries. Okay, so dorsal horns and dorsal column are only ones which are going to be spared. Everything else is just going to be infarct. There's an infarction over there. So it's going to present with upper motor neuron sign below the lesion, loss of pain, temperature, and sensations, which is spinothalamic tract below the lesion, and lower motor neuron at the level of lesion because of knocking out the anterior horns. And that's going to be all. But one last thing here is going to be that vibration, proprioception, and fine touch is all preserved in these patients with the rest being affected. And that is all for spinal cord lesions. Okay, now let's talk about Brown-Sequard syndrome. Here we have a hemisection. You can see this right there. Hemisection of the spinal cord. And the risk factors, the hemisection happen due to, most commonly, is going to be due to trauma or due to tumor. Okay, that causes the hemisection of this spinal cord. Findings are due to deficits in. Okay, so you are knocking out a couple of things. When you knock out the hemisection of diaphragm, for example, you have the anterior horn, right? You have the dorsal column, right? You have the corticospinal tract, spinocerebellar tract, right? So let's take a look at each one of them. So if you have a site of lesion, this is the level of site of lesion. You are going to develop at the site of lesion, at the level of the injury, you will develop ipsilateral loss of all sensations and lower motor signs at that level. Okay, and below that level, because you have knocked down the whole, let's say, 1/2 of the spinal cord, so there is going to be no connection that is going to go up from this level. So below that level, you're going to have a lower motor neuron sign and also impaired proprioception, vibration, fine touch, which is coming from the dorsal column right here, right? But on the contralateral side, because this side, why are we saying contralateral side here and ipsilateral here? Because this spinothalamic tract, which gives pain, temperature, crude touch, spinothalamic tract, it decussates as soon as it enters the spinal cord. It decussates right at that time. Well, the dorsal column doesn't decussate till it reaches the, I believe it was medulla. It decussates in medulla, so it's going to go ipsilaterally, decussates in medulla, go all the way. But here, the spinal tract decussates at the level it enters. So you're going to get a contralateral spinothalamic tract because you all these right, let's say this is the left side, all these left side fibers are going through this, through the other side of the body. So you have a lesion here, you are going to cause a contralateral side spinothalamic tract deficits, leading to contralateral impaired pain, temperature, crude touch, while everything else is just unilaterally going all the way up, right? For the dorsal column, it's going unilaterally all the way up and decussates in the medulla. For the upper motor neuron signs, you have this dorsal, you have corticospinal tract coming from the cortex and decussating again in the medulla, and then coming at that side. So it's already decussated. So you have, so again, simple thing, keep things simple. And that simple thing is that you would have at the level of lesion, you would have ipsilateral loss of all sensations and a lower motor neuron sign. So IL, lower motor neuron lesion, and loss of all sensations at the level of injury. Okay. On top of that, you will have below the level of injury. So this is at the level. This is below, right? So below the level of injury, you are going to get upper motor neuron sign symptoms and impairment of dorsal column, which gives impaired proprioception, vibration, and fine touch. So let's just read the book and then we look at the image again and get done with this one. So here we have all sensory pathway, ipsilaterally loss of sensation at the level of lesion. So all sensory pathway, let me erase this. All sensory pathway at lesion is out. Corticospinal tract, ipsilateral lower motor neuron lesion, flaccid paralysis at lesion. Okay, at the level of lesion, you have a corticospinal tract, which is out. Okay. And the next thing is about your corticospinal tract ipsilaterally is going to give you below a lower motor neuron lesion below the lesion level. So you have ipsilateral loss, lower motor neuron signs at lesion, and ipsilateral upper motor neuron lesion signs symptoms below the lesion. So just imagine the first two are, just do it this way. The first two is going to be your ipsilateral, and the rest is all about, I mean, it is ipsilateral, but the first two is going to be about at the level of lesion. So let's just say ipsilateral at this, and again ipsilateral below are these, and the other side is just contralateral. Okay. Let's just read this quickly. What we have is dorsal column ipsilateral below the lesion, spinothalamic tract contralateral below the lesion, all sensory pathway ipsilateral at lesion, corticospinal tract at lesion, causal lower motor neuron lesion, corticospinal tract ipsilateral upper motor neuron below lesion. And what's really happening here is, let's just do it here with this. So you have the sensations that are going, whatever is going ipsilaterally above here, you're knocking them out. So at that level, whatever is going through your corticospinal tract, because you're knocking out that nerve that would have came out, you're not actually knocking out your corticospinal tract at that lesion, but the nerve that would have come out and do its thing, which is a muscle contraction. So you'll get a lower motor neuron signs and symptoms, which is just mentioned at this point. Corticospinal tract ipsilateral lower motor neuron lesion at the lesion state. While the same thing, corticospinal tract will have a low or an upper motor neuron lesion below the lesion. Okay. So in other words, just remember one thing. Okay, simple. Let's make things simple now. You have a trauma tumor that causes the hemisection of the spinal cord, that causes that patient to have a couple of things. So first of all, they have the ipsilateral loss of, they will lose all sensation at that level, with the lower motor neuron signs at that level. And they will again have an ipsilateral below that level. They will have an upper motor neuron, and with the loss of dorsal column. On the other hand, below the level of neuron, contralaterally, they will have a loss of spinothalamic tract, which is impaired pain, temperature, and crude touch. So contralaterally, they will have impaired pain, temperature, crude touch. Ipsilaterally, they will have impaired fine touch, proprioception, vibration. Okay, and that's the Brown-Sequard syndrome. Let's just review this and move on to next. Here is just the hemisection. Ipsilaterally at the level of lesion, you will not have any sensation. Just imagine, let's say you have a knife, a trauma to your hemisection, half of the spinal cord, it gets destroyed, then you will not be able to have any sensation at that level. At that level, you have no sensation. But on top of that, because you have destroyed that level, you're going to have a lower motor neuron signs, right? And below that, because all these fibers are just going up through this pathway, so because you cut down this now, so you're going to have a upper motor neuron. Again, what was upper motor neuron damage? When you damage anything within the CNS or within the spinal cord, you are going to have an upper motor neuron lesion, sign symptoms, right? So because you knocked out the hemi spinal cord, now you will have now you knocked out, let's say, these corticospinal tract. corticospinal tract is coming from the cortex all the way to the spine. You knock this out, you're going to get upper motor neuron damage below the level of lesion. On top of that, you knocked out your dorsal column below that level of lesion for sure, right? Because they are going ipsilaterally all the way up. But you are going to knock out your contralateral spinothalamic tract because they decassate at the level they enter. They decassate at the level they enter. So you have, this is the perfect image. You are knocking down, your corticospinal tract because they're coming from top and going down. This is the corticospinal tract. You're knocking out your spinothalamic tract because they're decassating and going up. They're decassating and going up all through these levels. And you're knocking down your dorsal column because they are going there and decassating at the medulla. Okay, and here's the damage, and you can just figure out. Okay, again, just a summary. You will have, at the level of lesion, you're going to have loss of all sensations, and it's a lower motor neuron at that level. And it's all about ipsilateral because you damage. So think about it this way: you have more damage to the ipsilateral side. Wherever you damage, you can have a more effect over there. For example, you have a lower motor neuron lesion there, you have an upper motor neuron lesion there, and you also have a dorsal column lesion there, meaning a fine touch pain, fine touch vibration and proprioception. On the contralateral, the spinothalamic tract you will have a loss of your pain and temperature sensation because they are decassating at the level they enter, and that's all about Brown-Sequard syndrome. Now, important one, how you'll point is all about your Horner syndrome. If the lesion occurs above T1, you have a thoracic first vertebra, everything above thoracic vertebra. You have the sympathetic chains, remember, on the lateral side here. You have the sympathetic chains here. So if you're going to knock out your sympathetic chain, you're going to get ipsilateral Horner syndrome, meiosis, anhidrosis, ptosis, meiosis, and anhidrosis, right, on the ipsilateral side. And that's all for the Brown-Sequard syndrome. Okay, now let's talk about Friedreich ataxia. It is an autosomal recessive trinucleotide repeat, GAA, on chromosome 9 in gene that encodes for frataxin, which is an iron-binding protein. It leads to impairment in mitochondrial functioning, degeneration of the lateral corticospinal tract, which would give spastic paralysis, spinocerebellar tract, which would give ataxia, dorsal column, which would give decreased vibration sensation, proprioception, and dorsal root ganglia, which will give loss of DTRs, deep tendon reflexes. The patient will have a staggering gait, frequent falling, nystagmus, dysarthria, pes cavus, and hammer toes. Pes cavus is again, high arched foot. Pes cavus. It is also associated with what disease? Charcot-Marie tooth, right? You have hammer toes, both of them are associated with Charcot-Marie tooth. Diabetes mellitus, hypertrophic cardiomyopathy is the cause of death. High yield presents in childhood with kyphoscoliosis, as seen in picture A. You have a kyphoscoliosis. Friedreich is ferratastic, which is frataxin. He is your favorite frat brother, always staggering and falling, but has a sweet, big heart, ataxic gait. Okay, looking at this picture, we have a hypertrophic cardiomyopathy, which leads to what? CHF, and which leads to the other thing is cardiac arrhythmias. Both of them are the cause of death in these patients, but high yield is hypertrophic cardiomyopathy. Okay. Diabetes mellitus is there because it's affecting the pancreas. Kyphoscoliosis, basically affecting the vertebral bodies. And it's also high arched pes cavus, hammer toes. But importantly, let's take a look at the spinal cord itself. So we have this dorsal root, dorsal column, in the corticospinal tract, and most the other thing is spinocerebellar tract. So here we would have a spinocerebellar tract. cerebellar tract. They're all affected in this one. So it's very pretty easy, not that complex. But the simple thing is you have a trinucleotide repeat that causes normally what you have is there is a frataxin gene which is a mitochondrial protein. Frataxin is a mitochondrial protein which is an iron binding protein. It is present in high levels in brain, in heart, and in pancreas. So when you have an abnormal frataxin because of a trinucleotide repeat, it causes abnormal frataxin that leads to impairment in the mitochondrial functioning. Let's just change color. That leads to impairment in the mitochondrial functioning, right? So when the mitochondria does not function normally, you will get the degeneration of the spinal cords, different areas of the spinal cord. So lateral corticospinal tract mentioned here, corticospinal tract, and that gives the spastic paralysis, and that's the upper motor neuron lesion. Spinocerebellar tract, which is ataxia, as the name suggests there's an ataxia there, right? And the dorsal column, which is all about proprioception and vibration. Okay, dorsal column is affected, and dorsal root, which is about DTRs, is the deep tendon reflexes. Okay, so all of them are going to be affected in Friedreich ataxia. So if you can just memorize this picture, which is cardiomyopathy, diabetes mellitus, kyphoscoliosis, pes cavus, hamartose, and hypertrophic cardiomyopathy being affected affects the it is the main cause of death in these patients, and it causes CHF and cardiac arrhythmias, which lead to death. And these cord lesions, and that's going to be all for the Friedreich ataxia. Let's just quickly review this. It's a trinucleotide repeat, which is GAA. GAA, you can think about it as it has ataxia, so you can memorize this as a gait. GAAIT, gait right here, gait. So in these patients, you have a gait problem. You have all these problems. On top of that, you have upper motor neuron lesions, so spastic paralysis, decreased vibration, proprioception, decrease in DTRs, and decreased vibration and proprioception, all of that, right? And also on top of that, on top of everything, we have a gait problem. So GAA. Friedreich ataxia has a great problem. As the name suggests, right? Friedreich's ataxia, there has to be a problem in gait. So when you talk about gait, you're going to think about GAA. And there's a GAA trinucleotide repeat, which normally GAA was encoding for frataxin, which is the iron binding protein in the mitochondria. Okay, but when you have the abnormal, because when you have trinucleotide repeat, you have abnormal frataxin, which impair the mitochondrial functioning, and that causes all these problems. And that is all for the Friedreich ataxia. Okay, now let's take a look at cerebral palsy. It is a permanent motor dysfunction resulting from non-progressive injury to developing fetal infant brain. Most common movement disorder in children. Wow. It is multifactorial etiology, which are, for example, prematurity, low birth weight, and the strongest risk factors. They're associated with development of periventricular leukomalacia, which is a focal necrosis of white matter tracts. Again, periventricle meaning on the side of the ventricles, and on the side of ventricles, we have the white matter tracts. So when you have leukomalacia there's a focal necrosis of the white matter tracts. So it's going to present with an upper motor neuron signs, for example, spastic hyperreflexia affecting greater than one limb. Persistence of primitive reflexes, abnormal posture, developmental delay in motor skills, neurobehavior abnormalities, and excessive docility and irritability. Treatment, you have to give muscle relaxant like baclofen, high yield. Baclofen, high yield treatment point for this. It treats this. Okay, what's baclofen going to do? It's going to treat that spasticity, which was due to upper motor neuron lesion. So it's going to treat that spasticity. And what was spasticity? Spasticity is rigidness of the muscle, right? So it's going to treat that spasticity by stimulating. So baclofen will stimulate the GABA B receptors. GABA B receptors. And when you stimulate the GABA B receptor, you are going to cause increase in GABA, which is GABA is an inhibitory neurotransmitter. So it's going to inhibit that spasticity, leads to relaxation, and that's the mechanism of baclofen. Other thing you can give is botulinum toxin injection, selective dorsal rhizotomy. You can selectively cut down the dorsal column. Okay, prevention is prenatal magnesium sulfate for high-risk pregnancies and decrease incidence and severity, which will also decrease the incidence and severity. Now, high yield point in this with cerebral palsy is going to be a patient who's premature, who's at birth has a premature history of birth, or has a low birth weight, and you will see periventricular leukomalacia, periventricle on the side. So there's a hemorrhage there, in the periventricular side. Let's say here there can be hemorrhage on the periventricular on the side of the ventricles. It's going to present with upper motor neuron signs, with primitive reflexes being there, abnormal development, abnormal posture, neurobehavioral development, irritability there. Treatment-wise, you can give a muscle relaxant like baclofen, botulinum toxin, or selective rhizotomy. Prevention-wise, you can give magnesium sulfate. That's going to, for the high-risk pregnancy, decreases the incidence and severity of CP, cerebral palsy. And that is all for CP. Okay, now let's talk about common cranial nerve lesions. We have the cranial nerve 5, CN5 motor lesions. If you have a CN5 motor lesion, it's kind of jaw will deviate towards the side of lesion due to unopposed force from the opposite pterygoid muscles. Makes sense. But important point is that you have a lesion. Let's say you have a lesion here, the jaw is going to deviate to that side. Important in CN5. Let's take a look at the other one, which is going to be toward. That's cranial nerve 12 lesion. It's a lower motor neuron lesion. Tongue would deviate towards the side of lesion. Lick your wounds due to the weak tongue muscles on the affected side. So cranial nerve 12 lesion is going to, again, it's going to be towards the lesion. Tongue would deviate toward the lesion. So the mnemonic is lick your wounds. So you are going towards the wound side, right? So you have a lesion to that side. That's the wound. So you're licking that side. You're deviating towards the side of lesion. Why? Because you have weak tongue muscles on the affected side. Again, why did you have the jaw deviated to this side? Because you had the weak jaw muscles at the side where you have the effect. At the affected side. And that's why the opposite pterygoid muscles would just force you towards the side of lesion. Same phenomena here. Now let's look at the two other ones, which is cranial nerve 10 and 11. If you have a 10 lesion, the uvula would deviate away from the site of lesion. Weak side collapses, and uvula points away. The mnemonic is you go away. Or you go away as a mnemonic, so you can just have that. You go away. You go away. Don't want to talk to you, right? I'm just going to move the other side. So 10 is you go away. The next is 11. Cranial nerve 11 lesion is going to be weakness turning head away from the site of lesion. Sternocleidomastoid muscle. Shoulder droop on the side of lesion trapezius. Okay, there are two things. So we have weakness and turning head away from the lesion. So when you say you go away, right, you're just going to turn your head away on the other side too. Again, same thing. You go away, meaning that you're going to turn your head away from the side of lesion. So your head has turned away from the side of lesion. Your uvula is turned away from the side of lesion. But your jaw and tongue are different. They're like, nah, we are going to go towards the side of lesion. We ain't listening. This is the only way you can remember. You have a better mnemonic, go ahead. You can tell me, and I will be happy to hear that. But okay, what's our mnemonic? Okay, we got to know the nerves, right? So 5 and 12, jaw is going to deviate towards the lesion. 12 is about the tongue. So if you're moving the tongue towards the lesion, of course, your jaw is going to move there as well, right? So you just think about jaw and tongue being the same thing. Towards the site of lesion. Well, in the other case, you had this one, which is the 10 and 11. With 10 and 11, you are saying you go away. You go away means uvula, U for uvula. Going away is turning towards away from the lesion. And with the uvula, you would just think about head as well. Head would also turn away from the site of lesion. And that's just there. Okay, so now let's take a look at facial nerve lesions. Okay, now let's talk about facial nerve lesions. Bell's palsy is the most common cause of peripheral facial palsy. Picture A, you can see that. It usually develops after HSV reactivation. Okay. Treatment is glucocorticoids plus minus acyclovir. Most patients gradually recover function, but aberrant regeneration can occur. Other causes of peripheral facial palsy include Lyme's disease, herpes zoster, which is Ramsay-Hunt syndrome, which is a triad of ipsilateral facial paralysis, otalgia, and vesicles near the auditory canal. Sarcoidosis is the cause. Tumors, for example, parotid tumors, as the facial nerve goes within the parotid gland, it transfers through the parotid gland. So parotid gland tumor can obstruct the facial nerve. And diabetes mellitus, which can mess up with the cranial nerve 7, but as well as diabetes most commonly involves the cranial nerve 3. Okay, so now let's talk about how can we differentiate the upper motor neuron lesion of facial nerve versus a lower motor neuron lesion of a facial nerve. The location, right? So let's talk about the locations here. Okay, so in the upper motor neuron, the lesion of the location of the lesion is going to be the motor cortex right here. Connection from the motor cortex to the facial nucleus in the pons. So we have the facial nucleus in the pons, and it has two divisions. You have an upper division and a lower division. Upper division is supplied by both sides of the cortex. So we have a facial area of motor cortex on both sides. So it is supplying, the ipsilateral supplies the upper cortex, upper division from the ipsilateral side, as well as the contralateral side also supplies the upper division of the facial nucleus. And who supplies the lower division now, you might ask? Well, it's only supplied by the contralateral side of the cortex. So now, important point is, if you knock out this here in your upper motor neuron lesion, now you're knocking out two things. You're knocking out all the contralateral supply. This is contralateral and this is contralateral, right? All the contralateral supply to the facial nucleus in the pons. So you are knocking out, let's say, these two things. But guess what? Even if you knock down your contralateral supply to all of this area, you still have supply from the ipsilateral side of the cortex to the upper division. And all you're losing is just the lower division, right? So when you lose the upper division, okay, wait, let me go back here. So you still have a supply of your upper division. It is intact. Let me erase this part. And you have lost the lower, well, it was my black color, so let me just change to my color here. With a lower motor neuron, you were damaging all of this and this, right? But you still have, like I said, you still have ipsilateral supply that is going towards the upper division. So that upper division is going to be intact. So what is upper division supplying to? Well, upper division is supplying to, as the name suggests, upper division, meaning upper areas of the face and the eyes, right? Lower division, as the name suggests, lower division supplies where? Lower division of the face, right? So the lower division is just out. Now let's read when I fire. Now I hope now when I read, it's gonna make sense. So lesion is, again, it's at the motor cortex. It has to be above the facial nucleus in the pons. It could be anywhere here. Okay. Now affected side will be contralateral. Because why contralateral? We say because we affected this side, but the damage is where? No, it was a black color. Let me just go back and change my color to black. We damage this side because it's going towards the contralateral nucleus, remember? Because this deke is sitting here. So it's going to be contralateral side affected only at the lower muscles of the facial expressions. Muscle involved, only the lower muscle will be involved here. Let me erase this part. What am I doing? Okay. So just remember the red is coming here from this side. Red. It's coming from this side here. So it's intact. The black is the one which is affected. So here's the black. So the black is affected where? It's the, let's just write things down. It is the contralateral lower face which is affected. Okay. Now, what is spared? The forehead involvement, it's spared due to bilateral upper motor neuron innervation. Okay. Because you have innervation from this side, so that is intact. Okay. Now, other symptoms are going to be variable depending on the size of lesion. Okay. For the lower motor neuron lesion, let's talk about now lower motor. Lower motor neuron lesion, we have lesion could be at the level of facial nucleus, anywhere along the CN7 level. So let's just say we have this level right here, which is after the facial nerve comes out from the facial nucleus, we have a lesion there. So because we have a lesion here now, both the upper division is affected as well as the lower division is also affected. So you're gonna have upper face affected and the lower face also affected. And on top of that, it's you have lesion at the ipsilateral side, because these are the ones which are going to give supply to the upper and lower face. So you are going to have an ipsilateral lesion. So ipsilateral, upper and lower face, facial nerve, upper and lower muscles of the facial expression will be affected, and the forehead would also be affected. Now, symptoms would be you will not be able to close the eyes, incomplete closure of the eye, dry. So you are going to develop dry eyes, corneal ulceration, hyperacusis. It means you will hear normal sound as very loud. Loss of taste sensation of the anterior tongue. And this hyperacusis is all due to the fact that you have stapedial paralysis. So patient will not be able to tolerate any sound, any sound. Okay. Dry eyes because there is a decrease in tearing, decrease in salivation. Okay. And these patients will not be able to frown on the affected side. So they can't frown on affected side, meaning on the ipsilateral side or affected side. Okay. Loss of taste sensation to the 2/3 of the tongue, anterior 2/3 of the tongue, because that's facial nerve supplies that area. Okay. Angle of the mouth. Let's just zoom in and write more things here. Angle of the mouth is going to be drooling. Look at the angle of the mouth. Angle of mouth will sag. Okay. And you will have, importantly, you have loss of nasolabial folds. Nasolabial folds, important. If you ask the patient, can you expose all your teeth? They will not be able to expose all teeth. On the affected side, can't expose teeth. Okay. And that's going to be pretty much what we have. On the other hand, for the upper motor neuron lesion, what did we develop? We just developed the facial things. For example, inability to smile on the affected side. Loss of nasolabial folds here again. And drooping of the lower lip is there, but no problem in your lacrimation, your drooping of the eyelid or anything like that. And hyperacusis and loss of taste and all that will not be seen, because this whole area is supplied by the contra. Well, here it's supplied by the ipsilateral cortex. So the summary, let's just do the summary here. The summary is simple here. All you have to remember here is going to be upper motor neuron lesion will give you contralateral lower face deficits. And a lower motor neuron lesion will give you ipsilateral whole face deficit. And that's going to be all for facial nerve palsy.